want to start by thanking the organisers for asking me to present today, and I recognise a couple of faces in the audience. So hopefully today what I want to go through is we've heard some of the aspects of the genetics of tuberous sclerosis, but I want to sort of break it down. Everyone thinks genetics is quite complicated, but actually when we hopefully explain it, it's quite easy. And what the role of a geneticist is, and many of you may have seen a geneticist either initially at the start of the diagnosis or later on, but we do play a sort of an overall sort of role providing a lot of information. So I want to go through sort of, I'll touch on the diagnosis and management because that's going to be covered in other sessions, but mainly focus on the genetic basis, the inheritance, the risk to family members and children, because that's one of the main questions people come to us with, and then the role of genetic testing, which has now become readily available, and family planning, because that's quite a big issue, and that's sort of our role to sort of talk about that as well. So starting with genetic services, they are available in every state. The departments are usually located in one major hospital, and then they provide outreach clinics. So for Queensland, we're based in Brisbane, but we provide a service for the whole state. So this week I was in the Gold Coast and Cairns doing clinics, so we sort of travel around the state. And we receive referrals from GPs and all medical professionals, so they could be anyone who's looking after a person with tuberous sclerosis. And our department consists of clinical geneticists, so we are medically trained doctors and genetic counsellors, and we basically provide genetic counselling, which is actually quite a broad subject. So if we look at the definition of genetic counselling, it's an education process that seeks to assist affected and/or at-risk individuals of a genetic condition to understand the nature of the genetic disorder, the management, surveillance of the disorder, the inheritance pattern and risks to family members, the option of genetic testing, and the options for family planning. And I'm going to sort of go through each of those. For me, what I love about my job is imparting anything I know about a condition, everything I've read up, so that the patient feels more informed about their condition. With a condition like tuberous sclerosis, which is relatively common, there is information out there, but for some of the rare conditions I see where there may only be 3 or 4 patients in a country, it's very nice to be able to make that family quite empowered with that knowledge. So starting with the nature of the genetic disorder, as we've already heard, there are some very well documented diagnostic criteria, and sort of they're available on the patient website as well, and there is a handout outside. So it is truly a multi-system disorder, and as we've heard, features will continue to develop over a lifetime, and the diagnosis is made via these criteria, which can either be genetic, using a genetic test, or they can be clinical diagnostic criteria. So I've just sort of highlighted them, listed them there, but they will be talked about in more detail in some of the other sessions. And I guess the key thing is, as we've heard, that when someone presents with 1 or 2 features, it's important to look out for some of those other organ system abnormalities and obviously monitor that person throughout their lifetime. And I've got some pictures up there, but I'll skip through some of this stuff. With the management and surveillance, so again, the guidelines are there for surveillance and management of a person with tuberous sclerosis. And genetics sort of comes up at the top there, but originally when someone is diagnosed, whether it's a newborn child or an adult with this condition, we want to work out, is there a family history, is there a risk to other family members, and the option of genetic testing. And for us as geneticists, you may not see us as often as you do your neurologist or your renal specialist or your cardiologist, but there are specific points in a person's lifetime that you may see us. So again, another beauty of our specialty is we see people pre-conception, throughout pregnancy, as young kids and as adults. So we're trained in all aspects of sort of medicine. So you may see a geneticist in a pregnancy because you're concerned about a risk or an abnormality on a scan. You may see us when you have a new diagnosis within the family. We may then see family members because they're concerned about their risks, and then we will see that child as they grow up as an adult when they're thinking about having children themselves. So let's talk about the inheritance and the risks. So breaking basic genetics down to basics. So this is what I say to all my patients. So imagine your body is made up of millions and millions of cells. And within those cells, we have what we call chromosomes, which are essentially the packaging of all our genetic information. And in each cell in our body, we have 23 pairs of chromosomes. We inherit 23 from our mother and 23 from our father. And if you sort of unwind that chromosome, what you can see in this picture is the chromosome is made up of genes, and there are 24,000 genes. And I sort of describe genes like instruction manuals. One instruction manual is not going to cut it. And so genes consist of DNA. So the best way to think about genetic information is a cell is a bit like a library. The chromosomes are like the bookshelves, and the genes are the books on the individual bookshelves. So that's keeping it as basic as we can make it. And this just shows the sort of the resolution when we're talking about chromosomes and genes. The chromosomes, like I say, being the big bookshelves, and as you zoom in even more, it consists of hundreds and hundreds of genes which are spaced out, a bit like beads on a piece of string. So with tuberous sclerosis, as you've heard, we know that there are 2 genes associated with this condition, TSE1 and TSE2, and they actually play a really important role in various cell processes. And this is probably a little bit more simplified diagram compared to the one we've had earlier. And what you can see is TSE1 and TSE2 work in this pathway where mTOR sits, and that pathway is involved in various cell processes like cell growth, blood vessel development, cell metabolism, and cell migration. So that sort of helps to understand how some of the features of tuberous sclerosis occur. And generally, the abnormalities in tuberous sclerosis prevent mTOR from TSE1 and TSE2 act like brakes on mTOR, which is promoting sort of cell growth, and therefore if TSE1 and TSE2 don't work, that's where mTOR goes in overdrive, and that's where mTOR inhibitors sort of came into play. So that explains why mTOR inhibitors work. So we know that more cases are due to TSE2 compared to TSE1, and the key thing is, the terminology. When people are explaining genetics, I sort of say, when someone comes to me and say, oh, I have the abnormal gene, or I don't have the gene. We all have the TSE1 and TSE2 genes. We have 2 copies of both of them. It's whether we've got a mutation in them. So a mutation is a bit like a spelling mistake, and we all have thousands of spelling mistakes in our genes. Most of them don't do very much at all. It's a bit like me changing the word, a sentence, a cat sat on the wall to a bat sat on the wall. What we want is a significant spelling mistake or a mutation that actually disrupts what that gene does or how that book is being read. And that's what we're looking for when we're doing genetic testing. And we know that you can find mutations in either TSE1 or TSE2 in about 85% of cases. And as we've heard, TSE2 cases tend to be more severe than TSE1. So the inheritance pattern. Hopefully we should be able to go through this diagram. So what I have here is for any person who has a diagnosis of tuberous sclerosis, regardless of whether it's TSE1, TSE2, or whether we don't know the underlying genetic basis, the inheritance is always going to be the same, so autosomal dominant. And the way to depict it is we've got a sort of an unaffected parent here with 2 normal copies of that TSE gene. The parent here with 1 abnormal copy, so a mutated copy, and 1 with the normal gene. Every time the other partner has a child, they're always going to pass on a normal copy of this gene, so that will get passed down to all the various outcomes here. Whereas the individual with tuberous sclerosis can either pass the gene which has got the mutation in it or the one that doesn't. So that's where the 50-50 risk comes in. And this is 50-50 in every pregnancy. So it's like tossing a coin. I commonly get asked questions, so my first child has got it, does that mean my next child won't? It doesn't. Genetics doesn't quite work like that. It is like sort of tossing a coin every single time. A couple of the features we see in autosomal dominant inheritance, and this is true for TSE, but also other conditions that are inherited in this way, is when there is a clear family history. When you draw the family history out and start shading in people who are affected, this is what you tend to see. You can see multiple generations. There essentially isn't any skipping of generations, so you don't see people who have an abnormal gene who have no clinical features at all, which can occur in other conditions. This affects males and females equally, and it is transmitted by males and females equally. And this is where the 50-50 chance comes in. A couple of terms that we use when we're talking about dominant conditions, and particularly for tuberous sclerosis, it is 100% penetrant with variable expression. And what that basically means, expression is the degree to which a person shows that condition. So this is where you can see, if you lined up 100 people with tuberous sclerosis, that one person may be more severely affected than another, but you will also see that within a family. And we just don't yet know why we see that variability. And we suspect it's probably those other 23,999 genes that are modifying something. So we still need to learn about what these modifying factors are, and I think that's where research is hopefully going to progress. And then with the penetrance, this is what I was saying, that if you have the abnormal gene, so a mutation in the gene, 100% of people with that will present with a clinical feature. So that's why it doesn't tend to sort of skip generations. So it's important to understand this terminology, and I think a lot of medical people don't always explain this right. They always confuse the two, and they don't always understand this either. So Now we've heard about sort of family history, positive or negative. We know that in about a third of cases there will be a clear family history, and therefore that person, there is a 50% chance of passing this condition on. For the majority, however, that person you see is the first person within the family, whether they've been diagnosed as a child or as an adult due to a delay in diagnosis. And this is due to a number of different mechanisms. So the most common is what we call a de novo mutation. So for all of these genetic conditions that I see, they've got to start somewhere for the first time in a family. And so this would be a new mutation that may occur literally on day one as the egg and sperm come together. I sort of explain it a bit like you start off as one cell. That cell's got to photocopy 1,000,000 times to create a baby. If I was photocopying an encyclopedia, I'm going to make a mistake the same way the cell may make an error like that as well. We heard about gonadal mosaicism and mosaicism. So gonadal mosaicism, essentially what that means is although neither parent has any clinical features of the condition, they may have a few sperm or a few eggs that have the mutation. So that's what we call gonadal mosaicism. And in that scenario, we tend to say, for the negative family history, to incorporate the de novo mutations, the gonadal mosaicisms, the chance of having another child with this condition is 2%. Okay? So this is quite important when I'm seeing families where, let's say, an adult has been diagnosed and then their brother or sister is coming to me to say, well, what is my risk of this condition or me passing this on? It's important to understand the inheritance and the mechanism in the family to accurately provide the right counselling to that person, hopefully be reassuring for some families. So then the role of genetic testing, and this has become more readily available as we've learnt more about the gene. Genetic technology is sort of rapidly advancing, and sort of I have to constantly keep up to date with what's happening. When we think about genetic testing, we have to always think about what's the indication here. So from a diagnostic point of view, it's to find a TSE1 or TSE2 gene mutation. That's one of the diagnostic criteria. But you don't need to have a genetic test to confirm the diagnosis because there are very good clinical criteria. It is useful, however, in people who have suspected or probable tuberous sclerosis, where knowing a diagnosis now is going to be quite helpful rather than waiting till they evolve into maybe some of the other features. So we're getting a lot of patients referred now who just present with renal AMLs, but they have no other features, and we're trying to work out, do they have tuberous sclerosis or not, because you can see AMLs in the general population as well. So predictive genetic testing is for the at-risk relatives. So this may be a brother, a sister, an uncle or aunt who clinically doesn't have any obvious features externally. They haven't been investigated for all the internal features, but they want to know, are they at risk of this condition? And that's where predictive genetic testing comes in. So there's a role of genetic testing there. And then for reproductive options. So as everyone with tuberous sclerosis is growing up, they're planning children themselves, it opens up a number of pregnancy testing options, which we'll go through in a second. So when we think about predictive genetic testing, whether it's a child or an adult, a genetic test is never just a genetic test. It's not like a blood test you have for your kidney function, for your liver function. There are advantages and disadvantages to a genetic test. So if you have a diagnosis, a clear clinical diagnosis, it's the icing on the cake. It's not going to change very much for you. However, for at-risk relatives, whether it's siblings, young children, brothers and sisters of the child being affected, we need to discuss some of these issues because they can have quite significant effects. So before you can offer a test to an at-risk relative, you need to know what is the mutation within the family. So a genetic test always has to occur in an affected individual with tuberous sclerosis to find the mutation, because as we know, 15% don't have a mutation. Only after you've found a significant mutation can you offer a test to other family members or in a pregnancy. So that's the first thing that needs to occur. And then the process of genetic counselling. So that person who has a family member needs to have a better understanding of the disease, although they will be quite informed by their family, but to hear it from a medical professional, and then to go through the options of genetic testing. So when I'm thinking about a predictive test and I'm talking to someone, the advantages for that person are having a diagnosis. If there is a clear management plan. So for some genetic conditions, there isn't any treatment for it, there aren't any cures, there aren't any guidelines for it. So actually, there isn't always an advantage knowing at a young age. You can't do anything about it. Whereas for tuberous sclerosis, there are clear guidelines. There's a clear advantage to having a diagnosis and having the management plan. It does, it can relieve parental anxiety, so having a child with it and then their sibling. If they're really obviously concerned, we get a lot of parents who really need to know because they're very anxious for the other child. And then obviously reproductive planning. However, the disadvantages, for any genetic condition, we see a lot of genetic guilt. Parents have sort of come to us saying, well, was it this something I did in the pregnancy? Was it that glass of wine I had? And if they have the condition themselves, also that the guilt of sort of passing that on. And we always say, we can't change our genes. We inherit them from our parents. So it's the process of understanding that. Unfortunately, in Australia, there is the financial and employment discrimination with genetic testing, in that insurance companies may ask you the result of a positive genetic test. So you could be a well person, and as soon as you've got a positive genetic test, you have to put that down on your application forms. You could be completely healthy. That's not the case in Europe, and hopefully Australia is going to follow at some point in the future. Having a diagnosis, the stigma associated with it, and then the anxiety of symptom development. So if, let's say, we test a 10-year-old child because of their family history and they test positive, you then have the anxiety of any symptoms that may develop or when they're going to develop. Between siblings, we commonly see that there may be altered parental rearing, or, that, as we've heard already, you mustn't forget about the unaffected child with tuberous sclerosis. And then particularly with genetic testing in children, and I know some of this doesn't necessarily always apply with tuberous sclerosis, but there is that loss of autonomy. You're making that decision for that child, and they may not have wanted to know. And not so much with tuberous sclerosis, but with some of the other genetic conditions I see, which are adult onset, we tend to not test young children because there isn't a management plan and they may not have wanted to know. The availability, it's readily available. So if someone says to you, you can't have the genetic test, it's not available, that's rubbish. There is an Australian lab that offers the test, so that's in WA, in Perth, but we commonly send samples to various different overseas labs as well, depending on our personal experience. The genetic test is relatively straightforward. It's a blood test, can be done at any time of the day, along with your other blood tests. What's really important is the results can take many months. These aren't automated through a machine. It takes a lot of interpretation to go through these genes. Like I said, we have hundreds of spelling mistakes and errors, and we have to work out what is a significant mutation. And some of you may have gone through this process already. I know one person has, where we had a result which was inconclusive, and then we as a genetics team have to work out, is this a significant mutation, because we want to be giving you the most accurate information. And that can take months. I say the results take 3 to 6 months, and then it's all the work that happens afterwards. And like I said, it doesn't always produce a conclusive result. And the test is usually paid for by the medical team. So if you go through the genetics department, it'll be paid for by them, or if it's your neurologist, your nephrologist. Obviously, if you go privately, that's self-funded. So what happens to those who don't have an identified mutation? So that's the 15% of cases. And there are a couple of theories. So either the test is not 100% sensitive. So when we're picking a laboratory, we want to make sure that they have covered that gene from start to finish and there aren't going to be any gaps anywhere. They haven't missed out chapters, because we want to make sure we're doing the most accurate test. However, there probably are parts of the gene that we just aren't able to look at, sort of the preface or the appendix, and so that will change as technology evolves. There may be a third gene, we don't know. That's, I guess, where research is going to go in. And as we've heard, the other mechanism is what we call somatic mosaicism. So this is actually where some cells of your body have the mutation and some don't. So if the genetic test is a blood test and the mutation is not present in your blood, you're not going to pick it up. However, if you have AMLs and let's say a SIGA, and you were able to test that and that were to identify a mutation, that could explain why you couldn't find it in the blood. However, we don't start testing tissue unless you've had that removed. So that group is actually very difficult to sort of tease out, and hopefully we will get better at doing that. Even if you do test negative, it does not change your clinical diagnosis. If you fulfill the clinical criteria, you have a diagnosis of tuberous sclerosis. So everything we talked about with the inheritance, it's still a 50-50 risk. The only problem is that we cannot clarify that risk for family members. And so what we do, and this is what used to happen before genetic testing came in, was to clinically assess at-risk relatives. So when we used to see young children diagnosed with it, the parents used to have MRI scans, their eyes reviewed, their kidneys reviewed, to work work out whether they have any clinical features. And that is what we would have to do now for those families where there is no mutation. And what it also means is if we don't find a mutation, is it's very difficult to offer a test in a pregnancy or pregnancy testing options. So the final bit is, what are the options for family planning? So I'm covering this because we sort of talk about this in our consultations, and I didn't see a designated spot in the program, so I thought I could definitely cover it. The first thing to think about before even planning a family, particularly for females, is to discuss that with their medical team. So there are a number of issues that we have to consider for females. So what is the risk to that person of being pregnant itself? So this will be based on the severity of their lung disease and kidney disease in particular. So, you know, is their lamb so bad that actually the pregnancy is going to put an additional stress on their body? You've got to think about that person at the start. And that's something really important you have to think about and talk to your medical teams about. And then what is the effect of a pregnancy on the disease? So will the pregnancy increase the sort of the stress on the kidneys and the lungs? Will it make the AMLs worse, your kidney function worse? Knowing your kidney function is very important. Before getting pregnant, what are the effects of medication on fertility? And I think we're sort of starting to learn a little bit about what the mTOR inhibitors can do for fertility. So that's an important thing. But also, the effect of medications on babies. So some people who have renal disease are on ACE inhibitors, and we know that that is teratogenic for babies' development. So discussing your medication, even some of the epilepsy medications, is very important because some are not safe in a pregnancy, and whether you have to change the drugs is something you have to discuss. So all of this has to happen before we even think about starting a pregnancy, and these discussions need to happen a lot earlier on. So for that couple, they need to be fully informed about the risks of the children. So this is where we commonly then get a referral as a young adult with tuberous sclerosis. And the route taken for family planning is very individual, and it depends on the couple's own views. It should not be directed by anyone at all. Some of the conditions I see, parents didn't have children as they were told you should not have children. That is not what people should be saying. What's important is everyone has an understanding of what all the options are and what the risks are, and then that couple can make an informed decision. So the first thing is actually, for many people with genetic conditions, they actually do nothing. They actually just take that natural course. They understand there's a 50-50 risk. They may have lived with the disease. They're quite happy to take that 50-50 risk, and that's fine. And that's an important thing. There is still that backup option. The next thing is sperm or egg donation, prenatal testing, and pre-implantation genetic testing. So we'll cover those in a second. So with the doing nothing, so this is either for parents who have that low risk to having another child, so the de novo cases, that 2%. For some people, that 2% is still actually quite high. Some may say that's low, but some people, to them, 2% is quite high. Or it's for those who actually would never opt for a test in a pregnancy for personal religious reasons. And also for that group where there isn't a TSE1 or 2 gene mutation. So what is the backup plan when you do nothing, you just take a natural course? We wait for that child to be born, and then they are clinically assessed for all the various features, and they may be followed up to see, do they have the genetic condition or not? If there is a mutation in the family, then you may choose to have that child tested within the first few years of life, so you know whether they need to be followed up or not. I guess some people do go down the route of sperm or egg donation, depending on which side of the family the condition is coming on. Again, this is for the families where they don't want to pursue a pregnancy testing option, or where there isn't a significant mutation to offer a test within a pregnancy. So what are the pregnancy testing options? So these are invasive tests, and you probably would have heard about the chorionic villus sample and amniocentesis. But again, the biggest caveat, like the testing at-risk relatives, is you need to know what is the mutation within the family, and it's got to be a significant mutation, not one that's inconclusive. And both of these tests are available in the public and private system as well. And so the first test is a Cbs test, which can be done from 11 weeks into the pregnancy. And essentially what it involves is a needle either through the tummy or transvaginally, taking a sample of the placenta. And this does have a miscarriage risk of about 1 to 2%. The advantages of having the CVS is that you have the test earlier on, and therefore the result a little bit earlier on, especially if you are going to change the course of the pregnancy. So for those families who usually go for prenatal invasive testing, they are embarking on this because they understand the risks of miscarriage, but they would change the course of a pregnancy. And so this isn't for everybody. For other patients, they will go on to actually have an amniocentesis rather than a CVS, and this is done from 16 weeks into the pregnancy. And this essentially similar, needle through the tummy, and this is taking a sample of the fluid around baby. A bit like you and I, we're shedding skin and hair cells. Baby is shedding shedding cells as well, so it's testing the baby cells for that mutation. And this has a slightly lower miscarriage risk. And this is done a little bit later on, so the result occurs a little bit later on. And for some people, they don't have the option of a CVS because they present at 15 weeks because they hadn't realised they were pregnant, or the CVS is not able to be done due to various complications. And this is something that's becoming a little bit more readily available now and has a sort of a buzz in the media. So what we call pre-implantation genetic diagnosis. Again, it requires a significant mutation to be known in the family. Unfortunately, this is privately sort of self-funded within Australia, like all IVF is. And this is only done in specialised PGD centres, so you can't just go to any IVF specialist. And you'd want to go to someone who is has a specialised centre for this. And essentially what it involves is the IVF process. So this could be for fertile or non-fertile couples. So it is quite a daunting thing to go through if you are actually a fertile couple, but you're having to go through the process of IVF. So they create the embryos, and then, as you can see from this diagram, they take a sample of that embryo very, very early on and test it for the TSE1 or 2 mutation that's known in the family. And they will only put back the embryos that are unaffected. Therefore, you have pretty much a good guarantee that there won't be a child with tuberous sclerosis. However, this sounds really easy, as I've put it in 3 points. However, it is very complex. Financially, you've got to go through the cost of going through IVF plus the genetic testing. It is a really long process. You know, as you can imagine, IVF is a complex process. You've got to stimulate the ovaries, obtain the eggs, create the embryos, but the genetic testing, all the legwork that has to happen way before all that starts. So although you may have a known mutation within the family, the PGD centre themselves will have to do their own genetic testing to make sure that they can test for that mutation in the family, and that can take months before you even start the IVF process. And this is something that people don't always appreciate, and they again need to factor in when they're planning a family. So, you know, we always say to our families that, you know, when your child is in their late teens or early 20s, get them to come and see us then, because we can start talking about all of this. You know, if you're going to plan a family in 3 years' time, start talking about all this now with all your various medical professionals. Go and get all this information from the IVF specialist, because it may take that long to sort it all out. And actually, this is quite emotional and psychological, has a big impact, obviously, on the female partner as well. And like any IVF process, it doesn't have 100% success rates. IVF with itself, 25–30% of a successful pregnancy. You may have 10 embryos created that are all affected. There isn't going to be that 50-50 chance. So you have to appreciate that, and you may have to go through many cycles as well. So it sounds very easy. Not so easy, but it's important to be aware that this is available in most states now, and some people do travel interstate as well to specialist centres. I'm putting this in because a lot of young couples are hearing about this now, and this is becoming a bit more readily available, especially in the private field, what we call non-invasive prenatal testing. So we know that in a pregnancy, baby's DNA crosses the placenta into the maternal bloodstream, and you can probably isolate some of that DNA and measure it from a maternal blood test. And this is actually now being used to look for common chromosome abnormalities. So recapping on our genetics, chromosomes are like the big bookshelves. So conditions like trisomy 13, 18, 21, which is Down syndrome, and Turner syndrome. However, it's not yet available to test single gene disorders like tuberous sclerosis. However, there is a lot of work going into being able to do this for these kind of single gene disorders. So we're still in the early phases of chromosome abnormalities, but we may eventually get there. And this will avoid the need for an invasive test. So I think it's very important that when you're booking in with your GP and they say, well, okay, you've got tuberous sclerosis, let's just do this NIPT test. It's not covering you for this condition. You need to be aware what this test does and what the limitations are. And again, it is a screening test. So even if it does come back positive, sort of a high risk for trisomy 21 Down syndrome, you would then need to go on and have an amniocentesis or a CVS to confirm that. This is not 100% accurate. You get a lot of false positives as well, and not everybody ordering this test understands that. So a lot of stuff that I've covered today is actually on the TSA website. Hopefully I've sort of fleshed out a few bits, been able to explain some of the terms, and given you a bit of an overview. So I thought I'd stop there just so there's a bit of time for some questions.